Welcome to Global Healthcast, brought to you by Global Health Press. This is a special edition today on dengue vaccines. We have in the past already covered a general overview over dengue, and we also had a long interview with a colleague from Singapore on more clinical aspects of and management aspects of dengue. Now I have the pleasure and honor today to have with me Professor Tino Schwarz. Good evening, Tino, and a good many greetings to Würzburg.
Good evening, Joe. It's a pleasure to talk to you and to present you some data on the new dengue vaccine, which is now in our fridges to be used as travelers vaccine. So we were really happy that we have this new vaccine available now.
So that is available already. So we're a little bit late already, but I think for medical people, it's a little bit difficult to present about a vaccine or any medical product before it's licensed, right? So we are quite timely overall.
That's
Professor
right.
Schwarz.
It was licensed in December last year by EMA, and since February we are using it in our offices.
Very nice. Professor Schwarz is a well-recognized infectious disease physician. He is board certified in medical microbiology and in laboratory medicine, and he is head of the Institute of Laboratory Medicine and Vaccination Center at the Klinikum Würzburg Mitte and Julius Hospital. He is very well known among those who are involved in vaccines and vaccination. So, Tino, it is a great pleasure for me to have you here today. Thank you very much for joining us. And why don't you start your presentation on the TAC-003 live attenuated tetravalent dengue vaccine?
It's my pleasure. So now let's get started. First, my conflict of interests. I'm giving talks to various companies, usually on vaccines, and I've been doing clinical trials in vaccines for the last 20 years, also for various companies. So TAC-003, that's the generic name, is a new vaccine which was developed on the dengue type 2 backbone. There is one vaccine which has been licensed a few years ago using the yellow fever vaccine strain as backbone. However, clinical trials have demonstrated that this approach using the yellow fever backbone did not work as well as using a dengue backbone. And this company used the dengue type 2 backbone. And you see here what they did. They have actually replaced two genes, namely the gene for the pre-membrane protein and the envelope protein for type 1, dengue type 3, and dengue type 4, and inserted that also in the dengue type 2. So basically, we have now 4 attenuated recombinant constructs based on the dengue type 2 genome, including the dengue type 1, 3, and 4 genes. And that has the big advantage that, first of all, you get an excellent humoral response. That is due to the fact that the NS1 was preserved in the dengue type 2 backbone. And second, you also get a very good cell-mediated immune response due to the fact that the entire proteome is included. So, and this construct has been evaluated in clinical trials for several years now, and I will show you the highlights and the main data, the key data on the efficacy and also on safety. Any question to this construct, Joe?
Yeah, question. And just maybe as a reminder, I'm a little bit knowledgeable on tick-borne encephalitis vaccine, frühsommer meningoencephalitis. So it's also a flavivirus transmitted by ticks. And that also has the envelope antigen. So the envelope antigen is really very, very important for attachment and I guess uptake into the human cell. So it's a similar E gene, right? That is the relevant antigen that confers protection.
Right, but the problem is with dengue, we had this situation that we have the antibody-dependent enhancement phenomenon, which is typical for dengue infections, which you do not see in tick-borne encephalitis. So tick-borne encephalitis, you mainly only have one serotype, not like in dengue where you have 4 serotypes. So that's one of the major differences. But you are right, the envelope is very important. But what has been demonstrated during the clinical trials is that the NS1 is almost as important to keep the NS1 from the dengue backbone. While the flavivirus, the yellow fever backbone. Use the NS1 from the yellow fever, and that didn't work for protection against dengue. So that's the major difference between the two constructs.
Excellent. Thank you. That I did not know. Very interesting. So it is a dengue NS1 and it is an E antigen, and basically it's the whole virus then, right? It is a whole virus as a vaccine virus on a dengue virus 2 backbone.
Exactly. That's the construct.
Very good.
So let's look at the study sites. The study sites were mainly in Southeast Asia, Sri Lanka, Thailand, and the Philippines, and also in Central America and South America. You see there is no vaccine trials done in Africa, also in Europe, simply because if you want to look at efficacy, you have to go to the sites where dengue is endemic. So the company did the trials in these sites. In total, 20,000 or almost 20, a little bit over 20,000 participants were included in this trial, and the overall follow-up time so far is 57 months. The reason why this study was actually planned for such a long time is that there was this issue with the other vaccine which is available using the yellow fever backbone, and there was actually a problem in the seronegatives, and to avoid to see similar safety signals, the company had to do trials for over a much longer period to avoid any safety signals.
Okay.
So let's now look at the various endpoints which were studied. The first one was the primary endpoint, efficacy after 12 months. You see here there were the study was designed with 2 doses, 3 months apart. Blood draws before initiation of the study and 1 month after the second dose. Then the analysis was done after 12 months. That was the primary endpoint. Then secondary endpoints after 18 months, and then the long-term efficacy and safety follow-up for another 3 years. So in total, we have roughly 57 months follow-up time, and the study had participants 4 to 16 years old, and they received either the dengue vaccine or placebo in a 2-to-1 ratio. And 91% of the participants completed the trial over 4.5 years, which was the safety set. So overall, we have a very good overview over the whole time. These subjects were followed intensively, and so we're really happy that we now have a good set of data on this vaccine.
So, Tino, why children 4 to 16 years? Why no adults? And the second question would be, what was the endpoint here? When did you say this is a case of dengue?
The endpoint was, first of all, a virologically confirmed diagnosis by PCR or hospitalization, also virologically confirmed cases. So only cases who were tested positive by PCR were analyzed and counted as cases. The reason why the study was done 4 to 16 years old was very easy, because you had to look at a larger number of seronegatives. We know that these vaccines always work well in seropositives, but the important point is to avoid any issue regarding antibody-dependent enhancement, which was seen with the other construct, the yellow fever construct. One had to include seronegatives, and that was the case only in this young population. That's why the study was actually done in 4 to 16 years old.
Okay. And there were 2 doses,
3 months apart.
Okay. So the second infection, so to speak, was after 3 months.
The second injection was after 3 months.
Yeah.
You may ask yourself, it's a little bit of an unusual vaccination schedule. I mean, 3 months is very unusual.
Yeah.
In daily practice, it is also a little bit complicated for travelers' vaccinations, because they, if they plan a travel, they usually have either less than 3 months or more than 3 months. Those who have more than 3 months, for those you can do the 2 shots easily, but those who short. Those travelers who travel within, let's say, 6 weeks after they decide to book a travel, the schedule is a little bit difficult. But we'll work on it and we'll learn. how we can actually implement that schedule into the travel medicine space.
Yeah, so it is quite interesting, as this is a live vaccine. Other live vaccines are given much longer apart, right?
Right.
Usually, you don't have 3 months. You have much more, much longer interval.
You probably have to look at this from the perspective of an endemic country. If you vaccinate a pediatric population, you want to protect them relatively
Yeah,
soon. So
yeah,
an extended interval, well, let's say 12 months, is probably quite difficult to implement in these countries.
yeah,
Also for travelers, I mean, one shot now and let's say a second shot after 12 months would be a possibility, but we'll have to see how this will actually be implemented in our vaccination schedules and in our
yeah.
travelers ambulances, travel
Mhm.
ambulances. So let's now look at the set of data. Overall, after 12 months, we had an overall efficacy, irrespective of seropositivity or seronegativity, of 80.2% after 12 months after the second dose. Breaking this down to the seronegatives and seropositives, you see that the initially baseline seronegatives had an efficacy after 18 months of 66.2%, and those who were initially seropositive were at an efficacy of 76.1%. And breaking it down to the various serotypes, you see for dengue type 1 an efficacy of 69.8%, while dengue type 2 had a spectacular efficacy, 95.1%, due to the fact that they used the dengue type 2 backbone. That's why here we see the best efficacy. For dengue type 3, efficacy is a little bit lower, only 48.9%, and for dengue type 4, only 51%. However, if you look at the confidence intervals, they're very wide due to the fact that there were hardly any dengue type 4 cases during this trial, and that's why dengue type 4 could not be analyzed properly. The reason why dengue type 3 is a little bit lower is not really fully understood. I think there will be more research done to evaluate the differences between the efficacy between dengue type 1 and dengue type 3, which is, while 69 versus 48, you see that's a difference. So overall, we have a good efficacy after 2 doses over 18 months. Let's now look at the data for 57 months. You see here the follow-up time. You see the placebo group and you see the vaccine group for the seronegatives and for the seropositives. And you see that these Kaplan-Meier curves are actually separating nicely for both groups. So you have a sustained efficacy over time, 57 months, in these initially seropositives as well as in the initially seronegatives, which is very reassuring that there is no safety signal seen in this long-term follow-up of 57 months. So the vaccine works, and no safety signal seen, and also no waning of protection, which is also very important.
I really like the Kaplan-Meier plots. You can nicely see the difference as the gap opens between the placebo group and the vaccine group. So this is really impressive data. Yeah,
and
very
it's
nice.
also reassuring. I mean, you wouldn't expect that the curves will break the next month. That
Yeah,
is very unlikely. I mean,
yeah.
that's our experience from these kind of trials.
Mhm.
So some detailed analysis here for 4.5 years after the second dose, subgroup analysis by baseline seropositivity. You see here virologically confirmed diagnosis, and there's a continuing separation of the vaccine group and the placebo group, which demonstrates continuing efficacy, as you've just seen in the previous slide. And this clearly shows also that the vaccine has sustained efficacy in initially seronegatives and initially seropositives. So the main message from the slide is you can give this vaccine to everybody without testing, and that's one of the major advantages. If you compare these findings to the data for the for the dengue vaccine, which uses the yellow fever backbone. Here, the indication is only seropositives, which requires initial testing. While for the TUC-003 study, it clearly shows you do not require initial testing before you give the vaccination. And that's one of the major advantages, and also will be a major advantage in the implementation in endemic countries as well as for travel medicine.
Yeah, so exactly, that is the point. You can use it now in your hospital, right? You can use it in your vaccination center for travelers who go there. Actually, I may go to Asia again very soon, so I'm wondering if I should get this vaccine, because the people I know who had dengue in Asia, they really can tell you very unpleasant stories. Let me put it this way. So, yeah.
That's one thing, but you always have to keep in mind that it's not just dengue fever. I mean, if you run into the problem of developing a hemorrhagic dengue fever due to the fact that the time between the first episode and the second infection is, let's say, getting longer, I mean, the risk increases for getting a hemorrhagic dengue fever. That's why it's very important to have this vaccine now available also for travelers, not only for people in endemic countries, but also for travelers.
Very good.
So let's now look at the major endpoint, which is prevention of hospitalized virologically confirmed dengue. And you see the same Kaplan-Meier curve, and it's even more striking that there is even a major jump upwards after month 1 month after the second dose, which also shows that not only can you prevent virological dengue infection, you can also prevent hospitalization, and hospitalization is especially critical in endemic countries. So very efficacious in these clinical trials.
Good data.
So breaking down the data after 57 months after the first dose, here once again for seronegatives and for seropositives, overall efficacy 61%, seronegatives 53.5, and seropositives 64.2. And this is virologically confirmed dengue. So it's just the infection. And if you look at the data for hospitalization, you see here much higher figures, overall efficacy 84.1%, seronegatives 79, and seropositives 85.9% against hospitalization due to dengue. And I think that is the very important data, that you do not only prevent the infection, you also prevent hospitalization, and that is very important.
So VCD is virologically confirmed
confirmed dengue. Virologically confirmed
dengue, right?
dengue.
Right.
Yeah.
And before we had infection, this is the one with hospitalization. So more severe.
This is hospitalization, and this is the infection.
Right. And more severe disease is protected at a higher rate than just the infection, which happens with many vaccines, from pertussis to, I guess, RSV or whatever will come in the near future. Yeah. Very interesting.
So, and once again, breaking down all the data on serotype, serotype 1 to 4, seronegatives, seropositives for virologically confirmed dengue, and also for hospitalized confirmed dengue. The important message from this slide is, first of all, the pattern of continued efficacy against all 4 serotypes in seropositive populations. And in seronegatives is sustained, first of all, and second, the limited number of dengue type 3 and type 4 cases in seronegative, owing to the low incidence. However, we have not seen an increased hospitalization in dengue type 3 and dengue type 4, which means although the study endpoints were not really well confirmed to that extent that we had many cases for dengue type 3 and dengue type 4, we did not see an increase in hospitalization due to dengue type 3 and dengue type 4. So the vaccine also works for dengue type 3 and dengue type 4 in prevention of hospitalized cases. And that's also very important. Also, I must say dengue type 4 currently appears to be, while not circulating into that to that amount, which was previously expected or known.
Mhm. Yeah, I think this is quite impressive as it summarizes, and you see all the estimates of efficacy are well on the right side, and only the two
Yeah.
where you have few infections there, the confidence intervals are very wide, and you don't get the data that you like to see. But again, from biological plausibility, you would assume that this is in the same range in the end.
There were no questions from the authorities regarding type 3 and type 4, which could not be answered properly. So there was no problem with EMA
Yeah.
in the registration, in the labeling of the vaccine. So let's now look at safety. Safety is always important, especially if you have long-term data. And here the data are analyzed for 18 months, and it shows you that once again, 2 doses, 3 months apart, and then safety data up to month 18, post dose 2. And you clearly see there is no safety signal. There is no higher rate of serious adverse events between the vaccine group and the placebo group. There were no whatsoever non-investigational product-related serious adverse events. There were no investigational product-related serious adverse events. Numbers are extremely small. There is no signal whatsoever. And serious adverse events leading to investigational product withdrawal or trial discontinuation, there was also no difference between the two groups, and death also no difference. So overall, the safety data which were presented in these clinical trials were very reassuring that the vaccine can be used safely in seronegatives and seropositives throughout the endemic areas.
Very impressive, yeah.
So one of the practical issues for the travel ambulances is, can you co-administer the dengue vaccine with other travel vaccines? And here we have two sets of data now available. One is for co-administration with yellow fever. You see the protocol here: yellow fever plus placebo, or dengue plus placebo, or yellow fever plus dengue, and then 3 months later, second dose of dengue, or according to the protocol, either yellow fever or dengue. And the important point is both vaccines, yellow fever and dengue, can be given at the same session. Both vaccines were immunogenic and well tolerated when given sequentially or concomitantly. So there was no inferiority seen either for yellow fever or the immune response to dengue. So for practical reasons, we can co-administer the two vaccines in the same session. And the same data for hepatitis A, which was selected as a classical travel vaccine. Here also we have not seen any interference between the two vaccines when given either as co-administration or sequentially. So that is also very helpful in the scheduling of travel vaccines for travelers going out either to South America, Central America, or Asia, or also Africa.
Yeah. So this was age 18 to 60 years.
Yeah,
And
because that's the typical age for traveler vaccine.
right.
So this study was done in another setting where the vaccine was actually used as a travel vaccine.
And that was not in endemic area.
Non-endemic countries, yeah.
Okay.
So this reflects what we do daily in our travel clinics.
Yeah. And in the end, you look at, you compare the immunogenicity with co-administration versus no co-administration, but you have no efficacy data in this age group. You only confer by immunogenicity.
I mean, we have an almost 25-year experience with hepatitis A, and we know that certain levels of antibodies are protective against hepatitis A. The same we know for yellow fever. So if these GMTs are in the range which you would expect it expect from giving this vaccine as a monovalent dose. You can assume that the efficacy is comparable if you do a co-administration with yellow fever or with hepatitis A.
And you also compare dengue virus titers, right? You
Exactly.
Okay, very interesting.
So no interference was
No
observed.
interference, yeah. No difference in immunogenicity, yeah.
So what's the label now in Europe? The vaccine, as I mentioned before, was licensed in December last year, and it's indicated to be given to adults, adolescents, and children as from 4 years onwards. So that is a very wide range of very wide age range where you can give this vaccine. And I think for those who may, let's say, travel to Thailand or go to Brazil, this is a very good way to protect adults, adolescents, and children against dengue.
Very reassuring. And again, I may be one of the customers soon going to Asia more often. And I guess very interesting. Yeah. Yeah.
Well, one of the points which was probably not collected in your interview with Marco Safadi is that dengue is no longer restricted to the classical endemic areas. If you look at the outbreaks which we recently had in various European regions, we had this large outbreak in Madeira in 2012, was a really large outbreak. We had alone in south of France last year 65 confirmed cases of autonomous infections, and also we had cases in Spain, in Italy, in Croatia, also cases which were transmitted within the European countries. And recent data also clearly show that Aedes albopictus, which is one of the main vectors for dengue, is now also endemic in some parts of Switzerland and also in the southern parts of Germany, along the River Rhine, in the south of France, in the whole Mediterranean area. So in the long run, you can expect dengue to become also endemic in some European areas. That's why it's important to have a vaccine now.
Yeah. It is coming closer. Let me put it that way. I'm well aware of this. Yeah. Yeah. Very interesting. Thank you very much. And
so let me summarize the main findings. First of all, the new vaccine is a live attenuated dengue vaccine based on the dengue type 2 backbone, which differentiates it to the previous vaccine which was available. We have demonstrated a sustained long-term efficacy against hospitalized cases and also overall dengue infections, and that irrespective of the sero status at baseline, seropositives or seronegatives. We have not seen any safety signal. We have not seen any evidence of disease enhancement, especially in seronegatives, and we have not seen any increased risk of hospitalization in those who received the dengue vaccine. Overall, there have been 39,000 doses of dengue vaccine given during the clinical trials, which is also a substantial number, which has proven efficacy. So we have a good database. The implementation of this vaccine in national immunization programs in endemic countries will definitely have an impact on incidence, on morbidity, and on mortality in these countries. And also the vaccine is now available for travelers to endemic countries, which is a major breakthrough because up to now we didn't have a vaccine against dengue for travelers.
I totally agree with all the points, and particularly with the last one. The FDA has not yet. I have not seen anything from FDA on the license. Maybe a last question then would be: would you roughly know the price per dose? So you need 2 doses. What would be the price for the 2 doses?
The price per dose is 112 euro in Germany per dose.
Okay. Yeah. Very good. Tino, this was fun. Thank you very much for
Pleasure.
all your insights into this new vaccine and also into the trials and how they were done, and very good results. There is a license now. As the disease is coming closer to us here in Europe, and it is already very close to many in the endemic areas, this is really a good breakthrough. Thank you very much for your presentation. This was our Global Healthcast special today on June 12, 2023 on dengue with our special guest, Professor Tino Schwarz. You will find today's slide presentation as a PDF in our show notes. Please like, share, and leave your comments below. Thanks for joining us today. I am Joe Schmitt.
Goodbye.